I don't, I mean, I just can't believe we did it. Wow, what can we say? I have massively enjoyed giving this course. That's really the main thing I wanted to say. I've always wanted to teach an entire pathology course, and I know I could pretty much summarize concepts in a relatively digestible way. The thing that I never really knew is whether I could make it fun. And, I guess fun is very subjective. Well, it's really up to you to determine whether you had fun. But I have really, really had fun myself. And I guess that's really the most important thing, because I think if you have fun yourself, then it will show to everybody else. We're going to talk about some of the, like we did before in muscle and nerve, the genetic metabolic diseases. We're going to talk about the toxic diseases. We already mentioned most of the things that are specific or largely toxins to the central nervous system. We'll rehash them a bit. And then we cannot really do this course justice unless we spend a good amount of time on brain tumors as well and look at them, their behavior, and how they affect everything. So that's what we're talking about today. Good place to start is prions, the most mysterious little critters in the world. You know what? I've been given this prion discussion every year for 5 years, and I still don't really understand how those buggers can replicate without DNA. If Samir would like to enlighten us someday, that would be great. But the category of human prion diseases, for the most part, is generally the same as what we call Creutzfeldt-Jakob disease. Now, it's right now stylish to say Creutzfeldt-Jakob. A generation or two, they said Jakob Creutzfeldt. Why they switched their order of importance, I don't know. But one of the reasons is that if you said Jakob Creutzfeldt, that would be JC, and that might confuse you with the JC polyoma virus. So for practical purposes, human prion diseases due to infectious protein particles, that's what prion stands for, is Jakob Creutzfeldt disease. We talked a little bit about it in the infectious disease chapter. There's a disease called Gertzmann-Schussler-Scheiner syndrome, a rare infectious disease, which you'll probably never hear of, and it's extremely rare. But you have to know that if you hear that's also a prion disease. There's another rare prion-type disease called fatal familial insomnia. When the New Guinea people used to eat each other, including the brains, they used to get a fatal central nervous system disease called Kuru. So Kuru is a prion disease due to supposedly eating human brains. I guess there's not too much of that in the United States. There's most of the prion diseases are in animals. You're probably well aware, especially in England, of BSE, or bovine spongiform encephalopathy. That would be considered the bovine counterpart of human spongiform encephalopathy, which, like I said, for all practical purposes, is Creutzfeldt-Jakob disease. There are diseases in minks, there are diseases in deer and elks, which have been shown to be due to prions. The common features of all prion diseases that there's a particle, a protein particle. We know its exact chemical structure. It is the infectious agent, and apparently it does not have a DNA base. One of these days I'm going to understand that. The common disease of this thing, of these prion particles in humans and of course in cows, that they get demented. So, a mad cow moos like he's crazy. And prion disease in humans, the ultimate expression is a dementia. The thing that you have to equate with the word prion, however, is the word spongiform, because the common features of all prion diseases, genetic, human, animal, cannibal, is that in the brain, they cause spongiform changes. And if you think that means little holes in the brain, you're right, because that's exactly what they look like. And they're in areas where there's neurons and glia, so you know that this could very easily affect gray matter as well as white matter. And it's transmissible. All prion diseases are generally fatal, and there's no therapy. And for a while, it caused like a real horrible clamor in the pathology business because we were always terrified to do posts of people that had Jakob Creutzfeldt disease in fear that in the process of taking out the brain and having some of those little bone sand particles, getting in your face like sawdust, that we would get it. But as far as I know, no pathologist or nobody has ever got prion diseases or Jakob Creutzfeldt from doing an autopsy. Here's what it looks like. If you remember the classical features for coilings and secondary of proteins, we know its exact structure is 208 amino acids. The gene which codes for it is on chromosome 20. And the thing is about prions is that even though this looks like a nice little three-dimensional figure, like many proteins and enzymes, it requires a conformational change in its 3D configuration in order to do the damage that it does. And folks, here's the damage. Now I know if you were to erase these little white holes in the brain, and I hope you do with your mind, you would say, well, that looks like a pretty normal brain. Here's a neuron because it's big. Here's probably part of a neuron. The rest of these things look like glial cells. But do you see these little washed out areas again? Does the brain look like a sponge? If you were to call this a spongiform encephalopathy, would you be correct? Of course you would, because that's how and why the term spongiform encephalopathy is used to apply to describe the brain changes seen in all the prion diseases. So let's talk about the specific common run-of-the-mill CJD. It's only about 1 in a million. It's generally in older people. Does that mean the virus can sit around for 20, 30, 40 years before it decides to do damage late? Of course it does, and that's the general feeling. It occurs sporadically and not as an epidemic. Don't ever let anybody tell you otherwise. It is transmitted, however, from humans to humans. There are a handful of well-documented familial cases. If that perhaps means a genetic predisposition to the virus, that would probably be the most likely explanation. It's generally, once it does its job, it's a rapidly progressive dementia. And because we're talking about neurons, you know that that's primarily gray matter, cortex. We also know it can involve the cerebellum and many other places where there are neurons. It's fatal. There's no known treatment, like all prion diseases. Okay, so much for prions. Let's move into the topic of demyelinating diseases. Now, if you remember, and I hope you do remember, I told you that demyelination or demyelinization is a nonspecific finding with just about any type of brain injury, especially white matter injury, which makes white matter white, is the myelin. It's the fatty substance. However, there is still a specific family of primary demyelinating diseases which occur in the absence of other nonspecific causes which cause the demyelination. So the mother of all demyelinating diseases is multiple sclerosis. And yes, I can tell you there's a couple of others like acute disseminated encephalomyelitis and acute necrotizing hemorrhagic. These are things that technically are different from multiple sclerosis. Perhaps you'd have to be a neurologist to know the difference. Quite frankly, I don't. But there's a lot of MS variants. In fact, here, let's put this very simple. Multiple sclerosis is such a common primary central nervous system disease that probably when somebody comes in with subtle changes of CNS, multifocal CNS things, eye problems, blind spots, especially younger women in their 20s, 30s, 40s, it's generally known that it's a multiple sclerosis until proven otherwise. And even though there are other specific demyelinating diseases, multiple sclerosis swallows them all up in terms of occurrence and importance. But once again, remember again, even though multiple sclerosis, whatever that specific disease is, whatever causes it, by the way, we don't know, whatever it is to be remembered that just about any type of CNS injury, all of the things we talked about on Tuesday, can probably cause demyelination as well. Now, one of the really, really neat things about multiple sclerosis, or actually, I won't even get into that yet. No matter what people tell you causes it, viruses, autoimmune, believe it or not, here we are, 2010, nobody still really knows for sure. And of course, you would think, well, if it's a disease that nobody knows for sure, why not call it autoimmune? Well, that's why a lot of people do. If there's evidence that maybe a virus could be possibly involved, call it viral. But the fact is, we don't know. It's extremely high prevalence. Think about it. 1 in 1,000 people, most of them are middle-aged or younger than middle-aged women in their 30s and 40s. And there's many, many, many more women than men that get multiple sclerosis. If a man comes in to a neurologist's office with a central nervous system like syndrome, he'll be worked up for everything. If a woman comes in with a central nervous system, focal type syndrome, they'll probably assume she's probably some type of multiple sclerosis. And the problem with multiple sclerosis, no matter what causes it, is that it's primarily a disease that causes the myelin to dissolve. And believe it or not, even though that myelin or the insulation to the axons or the nerve fibers dissolve, the wires themselves often go relatively untouched. And in the area where there is demyelinization, as you would guess, it would probably be more white matter because that's where the myelin is. That's why white matter is white, because it's white because of the fat. It's fat because of the myelin. In the oligodendrocytes, it causes a thing called a plaque. And don't confuse plaque with an atherosclerotic plaque, because it's not a hard plaque. In fact, it's a soft plaque. It's also associated with gliosis and edema. And it's really, really good that it's associated with edema, because if it is, then that area is going to be whiter than the rest of the white matter. It's on MRI, because there's going to be more water, because there are going to be more protons. Classically speaking, a young woman in 30 and 40 comes in with visual problems, especially like blind spots. It's probably going to be very likely to be a multiple sclerosis patient. Over the years, some people are treating this with a whole wide variety of things like interferon and a whole bunch of things, steroids, sometimes intrathecal medications. But the fact is, some of them help, some of them don't. The fact is, it's a disease that goes on for many, many, many years with constant exacerbations and remissions. And when there's a lot of exacerbations, the MRI scan looks worse, and when there's a lot of remissions, the MRI scan looks better. I got to tell you a story about my aunt. She got multiple sclerosis. There were 4 daughters in my mother's family, and my Aunt Eleanor was one of the younger ones. And when she got horrible MS, they thought she'd be the first one to die, even though she was one of the youngest daughters. Well, I got news for you. She was the last one to die. She died just a couple of years ago, and everybody else had been gone for many, many years. Now, look, here's an MRI scan. And multiple sclerosis gave MRI spectacular importance, because MRI has a way of looking at edema if you tweak the protons a certain way by doing a process called T2 weighting. You could then see where the edema is. And the edema is where the demyelination is. And the demyelination also has gliosis as well. So look, do you see all these periventricular areas in the white matter of being brighter because there's more edema, because there's more demyelination? Well, that's MS. Look at the plaques here, how irregularly they're scattered. And don't forget, this is a T2 weighted image. There are ways of making the water look darker than the rest of the white matter rather than lighter. That might be what they call a proton density image or perhaps a T1 weighted images. But anyway, the fact is, when MRI first came out, everybody that had a presumptive diagnosis of MS was going in and getting their plaques visualized. And when they were in remission, the plaques were better. And when they were in exacerbation, the plaques were worse. Needless to say, because of the occurrence of these lesions, just about any brain type manifestation symptom could be possible. Now, you remember we showed you before that there are certain stains that stain the fat of myelin blue. This is a stain that stains myelin blue. So when there's relatively no myelin in the gray matter, you don't see the blue stain. Where there's a lot of fat in myelin in the white matter, you see it blue. So in an area like this, it's normally myelinated. But look, do you see this area right here where there's a big loss in the blue? Do you see a lot of this area here where there's a big loss in the blue? And just like in the MRI scan, a lot of it is periventricular, isn't it? Because here are the lateral ventricles. So it's really spectacular that these white areas on the myelin stain will also show up as white areas on the MRI scan as well. Here's some more plaques. And remember, sometimes when you cut through a brain now at autopsy, you have to be very careful before you call something a plaque, because and some of these may very well be blood vessels. But when you see an area like this, which has a definite loss of white now grossly, or perhaps an area like you see here, that's definitely demyelination. And by the way, you see this fuzzy little stuff inside the lateral ventricles? You know what that is, don't you? Anybody want to take a quick guess? I'll be thrilled if you guess what that fuzzy stuff is inside the lateral ventricles. Come on, somebody, give me a shot at it on the chat box. You know that's choroid plexus, right? Because that's exactly where it should be. Here is a plaque now, as you saw, with the lack of myelin or lack of blue in the myelin stain. And now if you go microscopically, I think you will agree that not only is this demyelinated, but there's an increase in the small glial type cells. So the really beautiful thing that I like about MS, it's a type of brain injury that shows all of the three classic nonspecific responses to CNS injury. You have edema, which causes it to show up bright on the T2 weighted images. You have gliosis, like you see here and here, as a increased number of glial cells coming into the demyelinated area. And thirdly, in this particular stain here, you can see some preservation of these black lines, which is a stain which stains axons. It's a type of silver stain that stains axons. So you can see, even though there's demyelination, the wires are still straight. So it's a relatively specific disease of the myelin and not the fibers that the myelin covers. Okay, so much for MS. Let's talk about the classical degenerative diseases. And let's talk about them anatomically. Let's go from the cortex to the basal ganglia, to the brainstem, to the cerebellum, even to the motor neurons, even as far as the spinal cord. That's the way you can group the CNS degenerative diseases. And remember, in this case, we're now talking about primarily matter, which has neurons and not a myelination problem. So let's talk about some of these degenerative diseases. And I bet you're going to know what the number one thing is already, don't you? In the cortex, which is where we're starting, the number one degenerative disease of cerebral cortex is Alzheimer's disease. And I'm going to throw out a couple of more names at you, and I think you should probably have a recollection for these names. I'm going to tell you that there's another type of CNS cortical dementia degeneration called Pick disease, named after Dr. Pick, who was a famous doctor that worked in Prague in the Czech Republic. And there's another disease called progressive supranuclear palsy, which means supranuclear. That's also a higher area in the brain. There's another thing called cortical basal degeneration, which is the cortex and the basal ganglia. And if you remember, the cortex and the basal ganglia have a very, very close embryologic origin as well. So that's why a lot of the diseases which involve cortical degeneration often involve basal ganglia degeneration as well. Last but not least, we could then, knowing that Alzheimer's disease is about 75 or 80%, let's say 75% of all of the cortical dementias, the next biggest category are vascular dementias. In other words, multiple infarcts or multiple infarct dementia. These other three things here, frontotemporal, PIC disease, PSP, CBD, these are all cortical dementias too, but they're all relatively very, very, very rare. But the one thing that they share in common is that they have an accumulation of a protein called tau protein, which is a protein that is coded by the tau gene, hence the term tauopathies. So if you wanted to say, if you're at a party and you want to look smart, you could say, well, you know, most of the cortical dementias are tauopathies. Then they're going to think you're really, really smart. Of course, in vascular dementia, you're demented simply because of a lot of strokes. And in Alzheimer's disease, even though tau protein has been described from time to time, most of the tauopathies are the non-Alzheimer's cortical dementias. Okay, so let's talk about Alzheimer's. We know it's very, very, very common. We all know that we have a fear of getting it. Every time I do something incredibly stupid, I think I'm coming down with it. When I can't solve a New York Times crossword puzzle in 10 minutes, I think, uh-oh, either he's making them harder or my Alzheimer's is kicking in. It can be in the family. That doesn't mean it's a genetic disease. It just means that there is a familial predisposition for whatever causes it. It primarily involves the cortex. That's the gray matter. That's the important stuff. That's the stuff you think with. And the two classical pathologic findings, or we could say three, are neuritic plaques, which are plaques of material outside the neuron. And then there's neurofibrillary tangles, which are substances that accumulate inside the neuron. We're going to see that. And then there's amyloid. And the amyloid is almost always accompanied by either the plaques or the tangles, more likely the plaques and the tangles. But I would say you should remember, if somebody asks you, what are the specific pathologic findings in Alzheimer's disease, you should remember neuritic plaques, neurofibrillary tangles, and amyloid. And here's a nice picture of Alzheimer's brain. And you look at it and you say, gee, this doesn't look like a terribly bad brain. But let's say you look at 100 brains a day, and you would say, well, you know what? This is a normal brain. And guess what? You would be right. Because do you see how the sulci here are relatively slits-like compared to the fatter gyri? Well, look, here's Alzheimer's brain. Do you see the prominence of the sulci now? They're so prominent, you could even see the veins that often lie in the sulci. So why are the valleys or the sulci prominent? They are prominent because of loss of the cortical gyri. Think about it. If you shave a hill, the valley will look bigger. So this is cerebral cortical atrophy. Okay, now if you go to the places where Alzheimer collects, which is the cortex, especially all the cortex technically, of course it's most noticeable in the so-called higher areas, frontal lobes, temporal lobes, you might see things like this. You're going to see these things called plaques, okay? And you're also going to see things inside the neurons called tangles, which often push the nucleus off to the side. Now, you might not appreciate that from this picture, but when you do a stain for a tangle, you know, which is a precipitated, phosphorylated neural tubule. Often it pushes the nucleus off to the side. And last but not least, if you see a little bit of a pink area like here, or perhaps even inside of a plaque, a neuritic plaque, you're going to say, this is kind of eosinophilic, it's kind of homogeneous, it's kind of amorphic. Isn't that what Dr. Bernarczyk told us was possibly amyloid? Remember, it's one of the forms of a substance which could wind up being amyloid because it is hyalinized. So a hyalinized structure could be a whole bunch of things, but one of the things it could be is amyloid. Okay, now here's another plaque. This is one in which you could see perhaps the fibers that comprise the plaque a little bit better. And wherever you see plaque, they're usually surrounding areas of amyloid. And remember, this is not the usual type of immune amyloid that we saw with amyloidosis, or the result of chronic immunoprotein deposition disease. This is a different type of amyloid called beta amyloid. Nevertheless, it could stain with Congo red, like the other stuff does. But the best way to identify beta amyloid is to have an immunostain, which shows a specific reaction against the beta amyloid. So look at all this beta amyloid in the brain. Now, folks, whether you want to believe this or not, you all probably have a little bit of beta amyloid in your brain. More likely, I have a little bit more than you because I'm a little bit older than you. But with Alzheimer's disease, this beta amyloid really builds up. Look how much there is here. There shouldn't be nearly this much. Here's another plaque, and they call them neuritic plaques because they're black and they stain like these little nerve fibers by the silver stain. But in addition, there is a hyalinized area and very, very close and very, very association to this extra neuronal substance called plaque. And you know damn well, if you did a Congo red on this bugger here and you polarized it, it's going to give you that green birefringence. And as we've seen many times this course, apple green birefringence with polarized light is amyloid. It can't be anything else. Here's the Congo red stain before you polarize it. It still looks pretty much like it might be hyalinized and therefore possibly amyloid, correct? Well, let's talk about the tangles now. We already talked about we already talked about the tangles, the plaques, I mean. So let's talk about the tangles. All you could say about these neurons, I don't know where they're from, but you could really say it looks like they're a little bit more thicker and fatter and granular and pinker, and it looks like that the nucleus in some cases is almost being pushed towards one pole of the side because of this accumulation of substance. Well, if you do a anti-neurotubule stain on this, you can see that these neurons are loaded with precipitated neurotubules, because that's exactly what tangles are. And here's the electron micrograph, and you can see here are tangles, and they're actually pushing the nucleus off to the side. And if you want to know specifically what an intranuclear tangle is, chemically, it's a hyperphosphorylated microtubule. Remember when we looked at the neurons and we looked at the axon, we had the 9-in-2 arrangement of the microtubule. Well, in Alzheimer's disease, they get hyperphosphorylated and they start to precipitate and they fill up the cell, even so much as to push the nucleus here off to the side. So that's what a tangle is. Now let's talk about the other cortical dementias briefly. There's no reason to go into them in great detail. You could read about them, but the one thing that they all share in common is that they are all clearly known as tauopathies because of a problem with the tau gene expressing a tau protein. So in the non-Alzheimer's cortical dementias like frontotemporal, you probably can guess what lobes that would primarily involve. You know, Alzheimer's can involve all of them. Pick disease, named after Dr. Pick. Progressive supranuclear palsy and cortical basal. These are all tauopathies. And you probably are wondering what tau protein looks like. Well, maybe we'll show you in the next slide. We don't know. But remember, these are all relatively rare compared to Alzheimer's disease. The one that is not rare compared to Alzheimer's disease is vascular dementia, because vascular dementia is a strong second for a cause of a cortical dementia after Alzheimer's disease. So grandpa goes bananas, most likely it's Alzheimer's disease. But if he's had a history of little strokes or even big strokes, it's a very good chance that it could be a vascular dementia. He's not likely to have any of these tauopathies as a third option, but he could. But they're all relatively rare compared to Alzheimer's, which is about 75%, and vascular dementia, which is about 20%. And all these other four things are only the remaining 5%, approximately. So one of the things that's really hard to do is to differentiate purely on the basis of MRI, multiple infarct dementia from MS, because once again, they both are associated with areas of edema, aren't they? Mostly the differentiation between MS and MID would be on clinical basis. MID would be a guy that an older person, perhaps male as likely as a female, that has a history of strokes, whereas an MS person is somebody probably that developed the disease early on in life, and it's more likely to be a female. Otherwise, like you see here, you know, this could really, if you just showed this to a really good radiologist or neurologist, he might say, gee, it's really hard to tell. However, do you see that some of these areas of edema also involve the gray matter, like you see here, or here, or here? And we told you that with multiple sclerosis, the edema associated with the demyelination and the gliosis is usually purely, relatively purely in the white matter. So on the basis of a picture alone, a good neuroradiologist, or even a good radiologist, or even a logical person, or even you might say, yeah, this is more likely MID than MS. Okay, let's talk about one more big topic, which we could also call a degenerative disease before we take our break. Let's talk about Parkinsonism. Now remember, now we're moving down from the cortex in the basal ganglia, and now we're going to the basal ganglia in the brainstem. So you see how we're moving anatomically? And we'll be talking about the primary disease that involve both the basal ganglia and brainstem. And if you had to give that one word, you could call it Parkinsonism. But you have to understand the difference between Parkinsonism and Parkinson's disease. Remember, Parkinsonism is strictly a term referring to basal ganglia and brainstem type symptoms, okay? Whereas Parkinson's disease is the single biggest cause of Parkinsonism, but there's a couple of other things like a disease called multiple system atrophy, as well as Huntington's disease, or what was formerly called Huntington's chorea. These all can produce Parkinsonism-like symptoms, but the biggest one and the most classic one, and the one we'll spend the most time talking about, is a bona fide Parkinson's disease. So what is Parkinsonism? Well, you know what? I would encourage you to Google or go to YouTube and put in some of these phrases I'm going to teach you now. And they are used by neurologists and internists and anybody to describe classical Parkinsonism-like syndrome symptoms. Remember, these are just symptoms. It's not the specific disease yet. One of them is sort of an expressionless face, or what they called diminished facial expression. Another thing is that they're generally a little bit slumped over when they walk or even stand, or kind of a sad sack stooped posture. There's generally a little bit of hesitation or slowness when they make voluntary movements. But the three buzzwords, there's a lot of buzzwords that are used with Parkinsonism, But the one I want you to try to remember is the word affestinating gait, cogwheel rigidity, and pill rolling tremor, because these are always the terms that are used at the top of the list when they talk about Parkinsonism syndromes. And you know, one of our pathologists here at Chicago Medical School has Parkinson's disease. It was a post-stroke Parkinson's disease. But when he walks, he doesn't take full steps. He takes short steps, but they're very fast. So when you see people taking short, fast steps, they have to be fast to get there. Otherwise, the paces are so small. They're only about a foot stride rather than 3 feet, which is a normal stride. That's what they call a festinating gait, short, fast steps. Also, if you ever seen a cogwheel, like inside of a watch, you know it doesn't move smoothly, like a wheel. It moves in a jerky movement. Well, that's how a lot of their muscles work. Their hands, their elbows, their shoulders. It's not a smooth motion to do something. It's kind of a rather than a. Another thing is the one that's really the most classical is what they call pill rolling tremor. You could Google or you could YouTube all of these if you want. If you've ever taken a pill in your hand and you just roll it, it looks like your thumb is sliding by your index finger back and forth all the time. Well, that's a pill rolling tremor. And it actually has a pretty solid frequency to it, like about, maybe 4 rolls a second. But no matter what is causing these Parkinsonism-like symptoms, and we know Parkinson's disease is the number one thing. We've already told you a couple of the other smaller things, like post-stroke, post-encephalitis, or another specific disease called multiple system atrophy. The thing that is common to just about all types of Parkinson's disease involve the areas of the brain which are pigmented with dopamine type compounds. And if you remember from your neuroanatomy, whether you cut the brain or not, you remember when you were slicing that brain, even if you're just looking at pictures, you always came across a pigmented area in the midbrain called the substantia nigra. And that's why it's called substantia nigra, because it's black, it's pigmented black. There's another area that is just as black, in the pons called the locus ceruleus, and it's also black. Well, the common thing with all types of Parkinson's disease is that this black area is not as black as it should be. In other words, the DOPA type compounds inside of the neurons are depleted. And that's why L-DOPA helps the disease. Look, here's a midbrain. Remember, you got the substantia nigra there? Well, what if I was to show you an exact picture of another midbrain, like here, and it didn't hardly have much pigmented substantia nigra? This would be a great board question. If they let me do a board question, I would put this thing on there, and I would say, what disease is this? And you should know, because if it's normal here, and it's normally pigmented substantia nigra, and the neurons are depleted of pigmented DOPA-like compounds here, then you know that that's the guy with the Parkinson's disease. Similarly, do you remember the locus ceruleus? I got a little crazy on this because I always spelled it C-E-R-U-L, but then I saw some of the literature going C-O-E-R-U-L, and I found out by doing a Google search that the C-O-E-R is about 4 times as common as the C-E-R. Anyway, the locus ceruleus is another pigmented area, and as you might guess, it loses significantly that pigmentation with Parkinson's disease. Now, you want to look at it microscopically? Okay, look. Why are these neurons pigmented? They're pigmented because they have DOPA-like pigmented compounds in them. If you were to take the same area now, this could be from the locus ceruleus or the substantia nigra. And by the way, this is why it looks black. And you can see that it's not nearly as much pigment as it should be inside these neurons. That's Parkinson's disease. But it wouldn't be fair if I didn't tell you there's another very specific finding. I think you should probably memorize this image also. It's called a Lewy body, Lewy body. And it's also found in Parkinson's disease. And as you could see, it's inside of a neuron. And as you could see, it's very, very, very hyaline looking. It's homogeneous. It's like a protein aggregation. It is a protein aggregation. Well, the name of the protein is alpha-synuclein. So I think you should remember that alpha-synuclein and the reaction to it causing a homogeneous hyaline area inside of a neuron is what also found in Parkinson's disease. And you'd probably say, hey, should we do a Congo red on this? Well, you can, but if you did, it would be negative because it's not amyloid. It's alpha-synuclein. Remember, alpha-synuclein, Parkinson's, amyloid, Alzheimer's. Remember that? Okay, so let's talk about the clinical features. We already told you the symptoms. It could progress into hallucinations, dementia, and if it's a classical Parkinson's disease with loss of pigmentation, if you replace that with a form of dopamine which crosses the blood-brain barrier, or L-DOPA, most patients get a very spectacular response. And I think the guy that figured that out got a Nobel Prize. And in my opinion, he should have probably gotten about 10 Nobel Prizes because the response to Parkinson's disease with L-DOPA is spectacular, and it is still the main type of therapy for Parkinson's disease after all these years. Remember, we told you that there's another disease called multiple system atrophy, or MSA, if you will, and it's a wide family of diseases, but like Parkinson's diseases, it also shows up as precipitates of alpha-synuclein, and it's primarily in the oligodendrocytes rather than the neurons. But it also has Parkinsonism-like symptoms as well. And what do we want to show here? Well, what we want to show here is that there's a way of, like we saw with the in substances in Alzheimer's disease, with Parkinson's disease, you could get a specific stain which reacts with alpha-synuclein, a specific labeled colored antibody, and then look at it. So you could pretty much diagnose these diseases by looking at how much alpha-synuclein is in your brain sections. Last but not least, I also mentioned that there is another type of degenerative disease involving the basal ganglia. And this is a rare, but it's genetic and it's familial. It's called Huntington's chorea. And if you look up the definition of the word chorea, not North Korea or South Korea, but C-H-O-R-E-A, I think it comes from the word snake because sometimes they have like either snaky or jerky type movements. And remember, we told you that rheumatic fever, you have a type of chorea called Sydenham's chorea. But with Huntington's disease, you have a different type of chorea, but they both look the same. So that's why Huntington's disease is now called Huntington's disease. For many years, it was called Huntington's chorea. It's also progressive and fatal, and it also involves atrophy of the basal ganglia. And look how dilated these ventricles are, and also look how you can hardly see any basal ganglia material as well. So there's very significant atrophy of the basal ganglia here too. We're going to take a break because it's almost 10 o'clock. And Samir, we've covered diseases of the cortex, diseases or processes in the cortex and basal ganglia. And now with Parkinson's and Parkinson's-like diseases, diseases of the basal ganglia and midbrain. So let's move on down to the cerebellum. And we can talk about the cerebellar cortex. We could talk about its connections into the spinal cord, and even far down is to the peripheral nerves. You can see we have a logic to our madness here. We're actually taking like in most diseases, an anatomic approach to disease classifications. Uh, the one feature of all cerebellar diseases is the symptom of ataxia. Ataxia can be confused with a lot of things. There's nothing totally spectacular about it that makes it unique, but ataxia is best defined as a loss of extremity muscle coordination. Because as you know, that's what the cerebellum does as its main job. Some people even seem to think that there's even cognitive functions in the cerebellum. I don't know though. When I think I'm thinking from the top of my head, not my posterior fossa. Part of cerebellar processes, though, are also spasticities. And remember, these fibers are actually leading down through the spinal cord and into nerves. So some of the features of spinocerebellar degenerations, which includes the cerebellum and the spinocerebellum, is neuropathies as well. So we might as well start out with diseases now of motor neurons. And the classical disease, primary central nervous system disease, involving degeneration and death of motor neurons is ALS, for amyotrophic lateral sclerosis. And as you might guess, it occurs laterally and distally in the distal portions of the hands and the feet, progressing centrally, and it's muscle atrophy. It's progressive, and eventually it'll progress into the central, more important muscles like the diaphragm. So eventually this is a fatal disease, and that's what Lou Gehrig had, one of the most famous Yankee ball players of all time. That's why it's also called Lou Gehrig's disease. And also a little guy, a Cambridge professor by the name of Stephen Hawking also has it. It seems like he has been under pretty good control in general. But another situation which might involve degenerative diseases of motor neurons is the bulbospinal atrophy, or Kennedy syndrome, which is relatively rare, and I'm not going to go into it, but you should know, if you hear of bulbospinal atrophy or Kennedy syndrome, you're talking about basically a motor neuron. So you're talking about atrophy of muscles again, and also spinal muscular atrophy. You would guess that if the neurons controlling the muscles are degenerated, there's going to be atrophy of the corresponding muscles. So let's talk about the mother of all neuron degenerative muscular diseases, ALS. Once again, nobody knows what causes it. If you read an article by some jockey that thinks he caused it, chances are he should take a number. Everybody thinks they know what caused it. It's still really unknown. Could it be viral? Could it be autoimmune? It's always a toss-up for generations in that category. But the one thing clinically that happens, that there's a loss of motor neurons, both the lower body neurons and the upper motor neurons as well. A good percentage of the cases run in the family, not necessarily because there's a single gene that causes disease, but once again, you have the soil theory or the genetic predispositions to whatever causes it. And as you might guess, the disease progresses distally at first. Maybe you could see some prominence of the spaces between the fingers or muscle atrophy in the hands, then in the forearms. Eventually, it will move its way up into the diaphragm and the deglutition muscles, and that's how it does its really, really bad and often fatal things. And that may very well take years as well. The anterior horn cells can be reduced and gliotic, because that's where the disease is taking place also, in the anterior, or if you will, ventral horn cells. So if they die, the motor unit, or the muscles that they control, atrophy and die also. And there are the two biggest poster boys for ALS. One is the guy they named it after, Lou Gehrig, if you're a baseball fan. And if you haven't read A Brief History of Time, you should read it. It's the only book I've ever read in my life that attempts to explain what the hell is the whole universe about. And he does a pretty good job of it. He's a brilliant, brilliant guy. So as you might guess, It does not affect cortical neurons. This is the world's smartest guy, and he has an extensive motor neuron disease. If you look, there could be an ALS demyelinization of the cortical spinal tracts. Why? Because the upper motor neurons of the cortex are dying. So the cortical spinal tracts, where you could see them running, are also dying as well. Here's an area here. This is a typical area for cortical spinal tract. You should remember from a cross section of the spinal cord where all the general tracts are. Personally, I've forgotten most of them myself. And here's some anterior horn cells. And you can see that there are some pathologic changes in terms of degeneration and especially vacuolization as well. I wouldn't go so far as to call it spongiform, but when you look into these changes, it looks like there are very tiny vacuolar degenerations in the cells and around the cells as well. Okay, we got to hit the category of the so-called classical genetic metabolic diseases as well. And if you think of the concept when we were talking about the lysosome storage diseases, where you have disease of a specific enzyme due to a significant mutation of a specific gene, and therefore an accumulation of substrate, well, the same thing would happen in neurons too. So there's a whole family of neuronal storage diseases where specific enzymes are genetically absent due to mutations. It can also be inherited, as usually is autosomal recessive, in which you have then accumulation of substrates and therefore things that are being stored inside of the neuron and packing it up and interfering with its function. There's a big family of leukodystrophies, and if you want to consider those sort of myelinopathies as well, you can, but they're different from multiple sclerosis, and I'll show you why. And you should also remember, like we talked about with nerve and muscle, that you can have various deficiencies of mitochondrial enzymes caused by mitochondrial gene mutations, which can result in a whole myriad of central nervous system diseases. And I don't think that's worth going into. Or even if I did, well, no, I don't think it's worth going into. But let's look at the leukodystrophies. You probably should have a basic familiarity with some of these terms. I am giving you these terms and generally the frequency at which they're usually talked about. I've been to conferences in which they spend an hour on each one, but there's no reason to do that with you. All of the leukodystrophies are myelination problems. They are usually due to genetic defects resulting in enzyme defects where the enzymes are involved in proper myelin production and maintenance. So whether you're talking about Krabbe's or Krabbe's leukodystrophy or metachromatic leukodystrophy or adrenoleukodystrophy, or the one that I happen to remember the most from medical school because it's the most bizarre word I've ever heard, Pelizaeus-Merzbacher leukodystrophy or Canavan. These are all the family of leukodystrophies resulting in the abnormal production and maintenance of myelin. And that's about all we're going to say about it. So let's move on to the so-called toxic metabolic diseases. We've already mentioned in our chapter on alcohol and environmental that Wernicke-Korsakoff is a syndrome. It could be mild or it could be fatal. It can involve in hallucinations. It's always due to vitamin B1 deficiency, and it's almost always due to alcoholics that are not getting enough vitamin B1. And it can involve real changes or hemorrhagic changes in certain parts of the brain. We know that prolonged absences of vitamin B12 can cause a condition called subacute combined degeneration, or SCD, which results in the loss of the dorsal tracts in your spinal cord, which, among other things, are involved in vibratory sense. We know that diabetes can be just simply due to extreme hyperglycemia, a relative toxic effect on nerves also. We've also said in hepatic coma, as the final event, usually in hepatic coma. There's no longer the ability to conjugate the ammonia. You have free ammonia circulating, causes a very significant toxic effect on the brain. And that's usually the very last feature before a cirrhotic death. When people die from carbon monoxide poisoning, a lot of things happen. You know what happens to their hemoglobin, but the areas of the brain that are the most sensitive to hypoxia are the cerebral cortex, the hippocampus, and the Purkinje cells. So for example, if you were to have a hemoglobinopathy or a toxic compound like carbon monoxide, which is screwing up your hemoglobin, what parts of the brain do you think would be affected first? Cortex, hippocampus, Purkinje cells. So if you suspect a brain is having a toxic or anoxic effect, you would definitely take sections through those three areas to look for nonspecific pathologic findings. Methanol, in the old days, the drunks that couldn't get ethanol drank methanol, the ethanol with one carbon rather than two. And they wound up being blind the next day because it pickled their optic nerves. So methanol has a very toxic effect on the retina and on the retinal ganglion cells and on the optic nerve. Regular old alcohol itself has a toxic effect on the brain. You know that radiation can be a brain damager, although, if you remember what we said, of all the areas of your body that can tolerate radiation the most, the brain is number one on the list. We said that the lymphocyte was the most radiation sensitive cell of your body, but the one that's the most radiation resistant is your CNS in general. So your brain can tolerate a lot of radiation before it gets damaged. Of course, if you're radiating a brain tumor, you have to be very, very careful to try to be selective for that area. And the real fabulous success of some of these new brain radiation treatments is their ability to just zero in on the lesion itself, like the gamma knife. Chemotherapy in general is toxic. The one that's always given the worst reputation is methotrexate, and in particular, methotrexate in combination with radiation has always been known as a real scary thing for the brain. Here's a vitamin B1 deficiency. If you remember, I showed you this picture before. We're looking at the mammillary bodies, and they look like they're a little hemorrhagic over here. And that's exactly where the area of gross and microscopic pathologic changes would be. In Wernicke's encephalopathy, if it becomes severe, it's often called Wernicke-Korsakoff, even though technically there were two different syndromes. Here is a stain, probably a myelin-type stain of the spinal cord, as you could see, and the whole dorsal part, especially the tracts right here, are very, very washed out. They're degenerated. In other words, there's posterior column degeneration. Now, among other things, one of the big things that the posterior column carries is your vibratory sense. So that's why you have a tuning fork in your black bag, because if you actually put this tuning fork over parts of patients' bodies, especially the legs, the ankles, the bony parts, and they can't feel the vibration, you may suspect that they may have a disease which involves their posterior column. And the classical disease resulting in fairly specific posterior column degeneration is a vitamin B12 deficiency, severe and prolonged, called subacute combined degeneration. So when you hear of that disease, you think of a B12 deficiency, and you think of your tuning fork not being able to produce vibratory sense in your patients. Okay, down to the last topic. It's a pretty big one. And I like this one because I was able to make it my way with all of the gazillions of brain tumors I dealt with, either at MRI level or pathology level. I was very fortunate to be the main neuropathologist for our neurosurgeons at our hospital. They wanted only me because they thought I knew a lot about brain. And actually I didn't, but I learned a lot about brain when I worked for them. Most of the brain tumors, as we've said, are not proliferations of neurons. Almost all of the brain tumors are proliferations of the glial cells. So when we recited the list of all the glial cells of the brain, the astrocytes, the oligodendrocytes, the ependymal cells, these are the things that proliferate to form brain tumors. And we also said the reason why mature neurons do not proliferate is because mature neurons cannot multiply. However, there are some neuron precursor cells which can multiply and give rise to truly neuronal tumors, and a neuroblastoma is really the most classical example of that. There's a few others, but if somebody was to ask you a trivia question, what is the only central nervous system tumor that's a tumor of neurons? You could say a neuroblastoma. Some of the brain tumors, like a medulloblastoma, is also a form of a nerve cell proliferation, kind of like the Ewing sarcoma or the PNET tumor. Remember, we talked about the primitive neuroectodermal proliferations. Well, a medulloblastoma is in that family also. We're going to see good examples and basically features of all of them. We're going to talk about the single most common type of brain tumor, which is not really a brain tumor. It's a tumor of the fibrous dura, not the pia, not the arachnoid, but the dura mater, called the meningioma, which is, as you might guess, because the dura mater is a fibrous-like sheet. Meningiomas are very hard and rubbery. You can have lymphomas of the central nervous system. Before the AIDS epidemic, this probably wouldn't have been on the list because primary CNS lymphomas were practically something you never saw in your lifetime. And now with AIDS, half of every AIDS patient that comes in that has a brain lesion is probably going to be either a lymphoma or an inflammatory tumor called a toxoplasmoma. And of course, it's much more likely to have metastases occurring to the brain rather than a primary brain tumor. Here's the statistics. If a patient comes in and he got some weird CNS findings, so you send them for a scan and you see one big tumor in the brain, it's just as likely to be a single metastasis as it is a primary brain tumor. So if there's multiple lesions in the brain, it's much more likely to be metastatic than it is to be a primary brain tumor. What are the symptoms? Well, unfortunately, that would entirely depend on where the tumor was. And when you think about all of the lesions, theoretical, that if you gave to the brain would result in a motor or a sensory deficiency or a gait or an ataxia, you would generally have to play the game that way. And neurologists are very, very good at that. And even somebody that's taken a good neuroanatomy course like you should be able to figure that out. But in general, a significant brain tumor patient will have a headache. There may be some vomiting, mental changes, motor problems, in increasing severity, seizures. And if that tumor is allowed to keep expanding, you would think that eventually there would be increased intracranial pressure as well, resulting in increased pressure in the CSF. But remember, depending on where the lesion is, could very well determine what type of CNS anomaly it's going to express. So what do you do with the patient with the brain tumor? You take a history, you do a physical, you do a neuro exam. A good neuro exam is so crucially important. You do a lumbar puncture. Of course, if you expect that there's increased intracranial pressure, you may not do a lumbar puncture because you don't want to herniate the cerebellum through the foramen magnum. So that would, of course, be a thing you'd have to determine another way. One of them is to get your CT first and see if there's any evidence for increased intracranial pressure. You could do an MRI, which of course has a lot of good features to it as well. It's spectacular. If you cut a brain with an MRI scan properly, it's probably better than even a neuropathologist slicing the brain with a knife. And of course, there's angiography. And last but not least, it's so easy to do a biopsy of suspicious areas as well. And that was my job. They would stick needles into these little abnormalities in the brain, and I would have to tell them whether it was inflammatory, whether it was neoplastic, whether it was a metastasis, whether it was a primary brain tumor, whether it was, and if it was a primary brain tumor, what kind of brain tumor. But you want to know something? The good neurosurgeons probably pretty much know what it is already statistically. So always, always, always be friends with your neurosurgeons. Even though neurosurgeons in general are a little bit weird, they're very, very nice people. So, what are the things that you look at radiologically and clinically? Well, one thing you want to consider is whether the tumor is benign or malignant. There's ways of doing that even before you look at your biopsy, whether it's a primary tumor or metastatic. If it's a guy that has a known lung cancer and he develops a brain tumor, it's much, much, much more likely to be a lung met than it is a primary brain tumor. You want to know the location of it, and that you could tell very, very easily from your radiology friends. You want to know the age of the patient. If the patient is a certain age, for example, if the patient is a kid and it's in the midline of the cerebellum, you need a biopsy. You know the diagnosis. It's a medulloblastoma. You want to know what the density is of the tumor, whether it has a lot of calcium in it, whether there's liquefaction in the middle, which means it's growing so fast that it's outgrowing its blood supply and it's becoming liquefactive necrosis in the middle. What your MRI signals are, whether they're water signals, whether they're density signals, how much blood is going to it, how much is edema surrounding the tumor. And of course, even a small brain tumor that is technically benign, if it's compressing a crucially important neighbor that's vital to life, like a respiratory center in the medulla, it might as well be malignant because it's fatal. So do you remember I told you that most brain tumors are tumors of glial cells? Do you also remember I told you that almost any type of brain injury could result in gliosis? So sometimes it's very, very difficult from either the clinical or gross or pathologic point of view, or even the radiologic point of view, to tell whether something is increased glial cells just on the basis of nonspecific injury, or a proliferation of glial cells due to tumor. So once again, what are the features in differentiating gliosis, which is a nonspecific finding in any injury, versus a bona fide tumor or a glioma? Well, one thing is the age of the patient. If they've had a disease there, like a stroke, and you see gliosis, well, then you think it's probably due to that rather than a glioma. Whether it's in the gray matter or white matter, remember we saw that in differentiation of MID from multiple sclerosis. What's the gross texture of the tumor? Is it soft? Is it hard? How much blood is going to it? If it's extremely vascular, you might be thinking more of a tumor rather than a gliosis. Let's say that there's a lot of mitotic figures. Well, you would think, well, this is probably a tumor rather than just a benign party of a bunch of glial cells. What's the nuclear cytoplasmic ratio? Is the nucleus big? Is the nucleus dark? Are there a lot of calcifications? Is the gliatic area delineated very well, or is it general? Are there areas of glia around it as well? These are all factors in differentiating one from another, because quite frankly, when you look at something like this, and you know that these are generally glial cells, and you know that this is generally brain tissue, and they look like pretty well differentiated glial cells, you're going to say, well, shit, is this just gliosis due to some nonspecific injury, or is this a low-grade glioma? The point I want to make is a low-grade glioma is extremely difficult to differentiate from normal gliosis. From the gross point of view, from the CT point of view, from the MRI point of view, and even from the microscopic point of view. And here we are looking at a bunch of glial cells, and you don't even know whether this is tumor or reactive glial cells. Well, guess what, folks? Neither do I. But let's look at an area like this, and now you could say, well, some of these glial cells look a little big and look a little dark, and I'm pretty sure this is a glioma now. Well, now your level of confidence is being increased. Plus, it might have all the other features radiologically of being a glioma as well. The one thing that is absolutely easy to tell when you're looking at a glioma is if there is palisading of the glial cells. Remember palisading? kind of like lining up like little soldiers, as well as necrosis. You see this granular junk here and here. When you see palisading and gliosis, not only is it definitely a glioma, but it's a high-grade glioma. And the high-grade gliomas, if you go grade 1, 2, 3, 4, and 3 and 4 are the highest grades, the high-grade gliomas are also known by the term glioblastoma multiforme, or GBM. Those are the most feared and the worst behaving and the most nasty looking of all brain tumors. And if I was to ask you the question, what's the difference between a grade 3 or a grade 4 or a glioblastoma multiforme? The answer is there is no difference. But in order to diagnose either one, you need both palisading and necrosis, which I think you see here. Here's another high-grade glioma. And I think, I think you can see maybe the beginning of a little bit of palisade here, but you can also see some granularity of this junk. So, and maybe some granular or necrotic material here that's redder. So the point I want to make is all of the high-grade gliomas, even if they don't have an extreme amount of pleomorphism, they have to have necrosis. So here's the final question. What's the difference between a low-grade glioma and a high-grade glioma? The answer is necrosis. Here's a nice MRI scan of a glioma, and all you know about this tumor is that it's liquid on the middle. And remember, we showed you a picture of a brain abscess yesterday, and it was liquid on the middle because the center part of an abscess is usually more liquidy. Well, look, think about it. Let's say any brain tumor was growing very, very quickly. Well, if it's growing so quickly that it can't keep up with its blood supply, what part of the tumor is going to die and become liquefactive necrosis? Is it going to be the outside or is it going to be the center? It's going to be the center. So a liquid core, also called sort of a ring sign, is a sign of a rapidly growing brain tumor. And folks, if it's rapidly growing, it's more likely to be high grade than low grade. Okay, we're gonna have some fun now. In fact, we're gonna be interactive right now, folks. What are these cells? If I told you that these are normal glial cells, because they all have a little halo around them, like fat or maybe myelin fat, what kind of glial cells are these? A, astrocytes, B, oligodendrocytes, C, ependymal cells. Come on, let's have somebody be brave and give me an answer on chat. Thank you, Isla. Thanks for coming. I know you got the right term. Good. Those are that's classical textbook normal oligodendrocytes. Now, here's the second question. Let's say I told you that this was a tumor of certain kinds of glial cells. Do you think that the glial cells that are giving rise to this tumor are also oligodendrocytes because they look like oligodendrocytes, only there's a lot more of them and they're a little bit pleomorphic? Of course, this is a oligodendroglioma because it looks like normal oligodendrocytes. And here they are together. Normal oligodendrocytes, oligodendroglioma. Okay, game number 2. Do you remember I told you that there's only one type of glial cell of the brain that looks like columnar epithelium and it lines the ventricles? And what kind of cell would that be? Would it be an astrocyte? Would it be a microglia? Would it be a oligodendrocyte, or would it be an ependymal cell? What's the answer, folks? I know you all know it. Good, it's epi, right. So if I told you this was a normal ependymal cell lining of a ventricle, you'd say, of course it is. But What if I told you that this was a brain tumor now? And it's probably the only kind of primary glioma that may look like an adenocarcinoma because the cells from which it's arising look like glandular or epithelial cells. So, what would you call this tumor? If I told you it was a glioma, would you call it an astrocytoma? Would you call it an oligodendroglioma? Or would you call it a ependymoma? Absolutely. So here we go, normal ependymal cell ependymoma, and so on and so forth. And it wouldn't be fair if I didn't show you that, and this is something you should know because we've seen this twice already. What if I told you that this was a brain tumor as well? And you're thinking, well, shit, it doesn't really look like glandular epithelium. It doesn't really look like they have little halos around them. They don't really look like the glioblastomas. But you want to know something? I remember Dr. Minarsik told us in the chapter on pediatrics that sometimes when you see a little bunch of cells surrounding a central cytoplasmic area, that's called a rosette. Like here's maybe a rosette, like here's a rosette, here's a good candidate for a rosette. Do you remember the kind of tumors we told you that you see rosettes in? Here's one, here's one. It's the number one solid tumor of kids. This is a neuroblastoma. You can also have them in the brain. So remember, I told you there aren't too many brain tumors that are really proliferations of neurons. Well, these cells give rise to neurons, but they're not mature neurons, so they can still multiply. So this is a neuroblastoma. Here's the easiest one of all. I'll never forget this in my life. You're looking at a kid. You can see that there's something in the midline in the region of the posterior fossa or infratentorial, and it looks like it's in the middle of the cerebellum. There's only one tumor that's in kids that's in the middle of the cerebellum. And here, let me be a little more specific. If you see a tumor that is in the middle of the cerebellum and you have assessed that it's a primary brain tumor, then you know the diagnosis without even looking at the slides. It's a medulloblastoma. And by the way, medulloblastomas are also in this family of what they call PNET tumors. Remember, we called them primitive neuroectodermal tumors. We said that the Ewing sarcomas are in that family also. So what do you want to take home here? Medulloblastomas are midline cerebellar tumors in kids. Here's another nice picture of it in a sagittal view. And I think you could figure out that this is the cerebrum and this is the cerebellum because it looks like it. And there's something there that's irregular and greatly distorting and displacing the substance of the cerebellum in this midline sagittal view. Last type of brain tumor is actually the most common. You very, very, very commonly see these at autopsy, and really most of them are asymptomatic. And if you kind of remember from your basic anatomy, the distribution of the dura mater, remember it lies extensively, the falx is part of it, remember? Do you remember the tentorium is part of it, remember? Remember the whole covering of the hemispheres? Remember it actually is plastered onto the periosteum. In fact, it's part of the periosteum of the inner table. Well, where dura is where you find meningiomas. So if you see a parasagittal dense tumor and is maybe even close to the bone, it's probably a meningioma. They're usually very, very, very vascular. They're usually almost always benign. But the thing is, everybody talks about them being benign, but the neurosurgeons will really ream you out if you call a meningioma benign because they say, well, shit, you pathologists say all the meningiomas are benign, but I had a patient, it grew through the skull, it grew through the scalp, and then it grew through their hat. These things are damned invasive. Well, yeah, they can be, but like all brain tumors, whether they're gliomas or meningiomas, they don't metastasize outside the brain. Well, that sounds like sort of a stupid thing to say, because even if the world's most malignant brain tumor doesn't metastasize, it could kill you without metastasizing just from its location. So yeah, meningiomas can invade the skull. They can displace areas, but they're always in areas where you see a lot of dura, which is parasagittal, the falx, the tentorium, and all the venous sinuses of the brain. Remember all those sinuses, the straight sinus, the sigmoid sinus? Well, these are all made out of dura, aren't they? And that's where you have the meningiomas. If I was to show you a meningioma that neurosurgeon scooped out or took out, it always has the consistency of a super ball. It's always well defined, and microscopically, very often, here's a meningioma. Look how dense it is. Remember, this is a CT scan. There's the density of bone in this case. And look, here's another one that's firmly connected to the dura mater in the frontal lobe. But can you see how much it compressed that brain? Well, it may not have invaded the brain, but look how much it compressed. So, that could probably do as much damage as if it was invading it. Look, here's a microscopic picture. And they're fibrous cells because the dura is a fibrous organ. So they're generally spindly, and they almost always have this little whorled, WHOORELED appearance. And sometimes these little whorls calcify. And when a whorled nest of spindly cells in a meningioma calcified, it's called a psammoma body. Remember, we showed you psammoma bodies in papillary adenocarcinomas of various other organs, like thyroid, like breast, like ovary. Well, in the case of those adenocarcinomas, a psammoma body is a dried up papillary structure. But in the case of a meningioma, it's just a calcified whorl, because these are not glandular at all. Here's HIV. And it would not be fair if we didn't say a little bit about HIV, because it's such an overwhelming disease. And I've said this before, and I'll say it again. A space-occupying lesion of the brain in an HIV patient is either toxoplasmosis or lymphoma. And there's probably theoretically a couple of other things it could be, but 99% of the time it's one of these two. So before AIDS came around, primary lymphomas of the brain were practically unheard of. Now, half of the AIDS patients that have central nervous system have a lymphoma involvement of the brain. See all these lymphocytes? That's a lymphoma. Do you see this very well defined here? It looks like a mass. Even though it's an inflammatory disease, toxoplasmosis, remember, caused by Toxoplasma gondii, even though it is an inflammatory disease, it can form a very firm, almost mass-like appearance. And look how dense it is over there. Most of them are. Let's talk about the most common brain tumors, the metastatic tumors. Metastatic brain tumors are much, much, much more common than primary ones. And almost all the brain tumors which are multiple are metastatic. And even the ones that are single are about as likely to be as they are metastatic. But here's the statistics, everything else being equal. Guy comes in with a metastatic involvement of the brain, or a man or a woman. Most likely it's lung disease, it's lung cancer. In a woman, it's almost as likely to be a breast. But if it's a man and he comes in with a metastatic brain lesion, it's almost always lung. In a woman, it could go either way. And for some reason, which I can't explain, but you just have to remember it, for some reason, melanomas notoriously love to go to the brain early. Renal cell carcinomas. We told you that renal cell carcinomas love to go to the bone early. Well, they love to go to the brain early too. And, the GI adenocarcinomas, that's also on the list. And technically, as you know, anything can metastasize to the brain. But there's your top five. At the very top of the top five is lung. Do you remember we defined paraneoplastic syndromes before as syndromes that occur when there are neoplasms around, but they are not the direct neoplasm itself. And of course, most of our paraneoplastic syndromes that we've talked about so far have been like endocrinologic syndromes due to the fact that tumor cells can secrete endocrine-like substances like ACTH, for example. Well, there are about 4 or 5 common findings in patients that have widespread metastatic cancer, like Purkinje cell degeneration, and encephalitis or an inflammatory-like picture in the limbic system, or sensory nerve degeneration in the dorsal root ganglion, or clinically eye movement disorders. Patient comes in, elderly patient comes in to a good neurologist with one of these symptoms, and that good neurologist will think, holy shit, does this guy have a cancer somewhere? Of course, it doesn't have to be. But of all the cancers that can cause these various paraneoplastic central nervous system syndromes, small cells at the top of the list. So lymphomas are frequently mentioned. Breast could be possible. But if you want to remember what the big one is, it's small cell carcinoma. And that's why I'm going to increase its font to even a bigger size, because the majority of patients with central nervous system paraneoplastic syndromes are probably a small cell, but it could be a lymphoma, it could be a breast. Okay, last but not least, folks, here's your very last PowerPoint of your life from me. And we're going to just mention a few things at the end on familiar tumor syndromes. And we've already talked about them, but we'll mention them again. I do this because I personally don't think you'll see too many cases of this, but I think the board people would like to know that you're aware of the common familial tumor syndromes. Well, remember we talked about in neurofibromatosis 1, genetic disease, that these patients have not only neurofibromas, which is why it's called the original neurofibromatosis, but they can also have gliomas as well. And also remember that in the genetic neurofibromatosis 2 syndrome, rather than neurofibromas, they have schwannomas and meningiomas. You're just going to have to remember that. I think it's good if you do, if you can. And also there is another familial syndrome called tuberous sclerosis. And what these tubers are actually little overgrowths of tissue. They're not malignant, but they take up space. And in the central nervous system, anything that takes up space can really be bad. And the tubers of tuberous sclerosis are distributed as well as in other parts of the body, also in the central nervous system as well. Last but not least, there is another familial tumor syndrome called von Hippel-Lindau disease. And in it, you get hemangioblastomas. Remember, these are adults, and they don't have to be in the midline. Remember, we said medulloblastomas are midline cerebellar tumors in kids. Well, hemangioblastomas can be anywhere, but frequently with von Hippel-Lindau, they are in the cerebellum, and they're not necessarily midline. And of course, they're not necessarily in kids either. So we're done. We're done with everything. I don't really have that much more to say. Plus, our 4 minutes.